Just give me the countdown, Sai.
Papa, he has to count, one, two,
Yes,
three,
doctor.
count.
We are live now. We are
Live
live
now.
We can start the session.
Okay, good morning, friends. It's easy like a Sunday morning. A Sunday morning, you are all very relaxed, and today it's going to be a very relaxing wealth of knowledge, I would say, on cornea. And we have the TNOA Connect series. As the president of the Tamil Nadu Ophthalmic Association, I have great pleasure in welcoming you all for this 10th TNOA Connect series in the past 9 months. It's simply amazing to have all these institutions come together and covering every subspecialty of ophthalmology, starting from the mucormycosis with RAO, GOH, then pediatric ophthalmology, then cataract, refractive, with every institute. As you know, Tamil Nadu is the mecca of ophthalmic institutions across the country. And what I thought was, when I took over as the president in September 2021, that we should connect all the institutions. And that is the reason why we thought, okay, let us connect all the institutions and do this Connect series. And every month, the last Sunday of every month, we have this Connect series wherein we connect, communicate, and consolidate our knowledge. And we've been having a best of the faculty, the best of the institutions in this TNOA Connect series become hugely popular. And today also we've got the best of the institutions. We have the greatest honor of associating with none other than the Shankara Eye Hospital, Coimbatore. J.K. Reddy is the chief there, and he is going to be the master of this particular webinar, and he's going to take us forward in this cornea series. We also have an excellent faculty, which will be subsequently introduced by Dr. Manoj Vasudevan, our coordinator, also moderators, Dr. Srinivas K. Rao as well, and so many other people, Bhaskar Srinivasan from Shankar Netralaya, and all other stalwarts in cornea. And we're going to have a wealth of knowledge in this. As you all know, the theme for this year is Tamil Nadu Smiling and TNOA Shining. And we've been doing exactly that for the past 9 months, or 9.5 months, I would say. We had a series of programs. Almost every week, there's been 2 or 3 programs, starting from the TNOA ARC PG Catalyst Masterclass, which has become a huge hit among the postgraduates and the residents across the country. And then we have the Walk the Talk series, which has become very, very successful. And each of these luminaries of TNOA has been inspiring and motivating all of us with their success stories. And of course, the TNOA Connect series, and we had in the month of April, a very unique program, which is called the Gurukulam TNOA, which was conceived by Dr. Chandrasekhar and Dr. V.R. Vijayaraghavan. And all Sundays of April, and we had between 8 and 1, wherein 19 faculty covered about 26 different topics, which is again a very, very huge success among the, not only the practicing ophthalmologists, but also the postgraduates and residents across the world as well. So this TNOA Connect series is something which is very, very special. And today we have the Shankara Eye Hospital is partnering along with us, and we have got excellent faculty. And before we introduce the faculty, before we introduce the moderators for this, our President-elect, Dr. Ramakrishnan, who has been a source of inspiration and role model for all of us in Tamil Nadu Ophthalmic Association, and he's going to take over from me in a grand manner in the COVI conference in Coimbatore in the first week of August. I request President-elect Dr. Ramakrishnan to say a few words.
Good morning to all, and thank you, President Dr. Mohan Rajan, and dear faculty, panelists, and friends. A warm good morning to all of you. As President told, no, the TNOA is doing a lot of academic activities for the past 10 months. The beauty is, even though we have so many programs in the last 10 months, not even a single program we have cancelled or postponed. That's shows the hard work of the planning of our President Dr. Mohan Raj. I'm really very, very thankful to him, and also his untiring work of Dr. Mohan Rajan. Even during the last week, the election of All India Ophthalmic Association. No, even that he was touring all over India, but he was attending the meeting where he is in Gwalior or Indore or in Calcutta. He was attending the meeting from there. That shows his interest in Tamil Nadu Ophthalmic Association. Really, it's a very big thing. And of course, today, Tnoa Connect series is also one of the very famous, popular academic activity of Tnoa, wherein as mentioned by President, no, all the leading ophthalmic institute. So in that way, today, Coimbatore Shankara, under the leadership of my dear friend Dr. J.K. Reddy, is having a cornea update in corneal disorders. And of course, there's no need to say this. The faculty, especially my dear friend Dr. S.K. Rao and my dear Dr. Revati, Dr. J.K. Reddy, and all other Bhaskar Srinivasan, and all other faculty are very good. They're doing wonderful work in cornea for so many years. Definitely, this Connect series will be one of the best thing to be in corneal disorders in this. So I welcome once again, and also I'm eagerly waiting to listen to the update in cornea. Thank you, Dr. Mohan.
Thank you, sir. Dr.
Also, I
Ramakrishnan.
have to thank my dear Thangavel also, who are constantly attending all the academic activities, and also his presence is unique. It's unique, not the. He will make the surroundings so happy, and this thing. I'm really very happy to welcome Dr. Thangavel also. Yeah.
Very
Thank you,
unique, sir.
yes, sir.
2
Yes,
years
sir.
president.
Thank you, yes, sir. Ramakrishnan, sir, thank you. Thank you. I think, as you rightly mentioned, Thangavelu is unique in all aspects. The only president of TNOA who has completed 2 years successfully. And Thangavelu to say a few words, and then we go on to the moderators. I'm sorry, the coordinators, Dr. Manoj Vasudevan. I'll be filling my duty. Manoj Vasudevan, Nishant Madhivanan. Unfortunately, Nishant is held at the District Assembly in the Rotary. Will be joining us. Manoj Vasudevan, as you know, is a joint treasurer of the TNOA. Nishant is also is a member of the management committee. Both of them have been coordinating with Dr. J.K. Reddy for this wonderful webinar. Dr. Thangavelu, immediate past president, to say a few words.
Thanks, Dr. Morgan, for the 2 years of presidency. I must thank you for giving me this rare opportunity to be president for 2 years. And Mohan, always you have been doing this academic work. Apart from that, you have made Tamil Nadu, apart from Tamil Nadu smiling, you have made all of us smiling because of your smiling attitude, and listening attitude. That makes a lot of difference between other people and you. You listen to people and then you make them smile. And then in between the wits, which we can never forget in our lifetime, apart from the academic activities which have been constantly doing, which has been really an eye-opener in all the subjects. Say, I may be a corneal surgeon, but I look at something different. I watch the full panorama of ophthalmology. That you have made it possible. And apart from this also, administrative side also, especially taking forward the GST, which our treasurer has taken forward with your help and got the numbers also. The new number for the GST, that's real achievement. It is not simple. It may look a little simple, but completing the accounts on time, all that you have been in the background doing so much job. The next thing is welcome Dr. Ramakrishnan to the next president in Coimbatore. Red carpet welcome by Dr. J.K. Reddy, who is the organizing secretary. He has never left. He is not going to leave even a stone unturned. So we are going to give you a warm reception. And Mohan, thank you for this opportunity to say a few words.
Thank you, Thangavelu. And I'd like to acknowledge the support of all the TNOA members for my post as the vice president of the AOS elections. With your blessings and support, I sincerely hope that I'll be able to see the victory, which will be on the 4th of June. I once again thank, and Dr. Loganathan, our treasurer, has been doing a wonderful job. Loganathan, just a few words from you, and then we go on to Dr. J.K. Reddy.
Good morning, sir, respected president and other office bearers. Actually, we are last almost more than 10 months. We are actively involved in academic. This is one of the best programs by our president for encouraging on Sundays and Fridays and other days for all webinars, which is very useful not only the postgraduate as well as the practicing ophthalmology. So many take-home message from the masters in respective fields. And wish you all the best. Definitely, we are going to celebrate the results of PIO selection, sir. So we are waiting for that. So thank you very much to one and all. Sir. Thank you.
Thanks a lot, Loganathan. Over to Dr. J.K. Reddy. Manoj, you would like to? Yes. Manoj and J.K.
Sir,
Yes.
Dr. Nishant will now introduce the moderators for the session.
Nishant has come in.
Yes, sir.
Fine,
I'm here,
good.
sir. Very good morning, sir, and all the very best for your Vice President, sir. Very good morning. I would like to be very happy and thankful for this kind of Cornea session being conducted. The moderators, my guru, Dr. Bhaskar Srinivasan, who is the head of ocular surface in Shankar Nethralaya, and Dr. Srinivas K. Rao, whose talks are always exquisite, unique, where not even one point to be missed in terms of that. And Dr. Revati ma'am, who's always an inspiration to all her PGs. Thank you so much for moderating the session. And J.K. Reddy sir, as always, being very unique and different. He comes up with amazing ideas, amazing thoughts. So we are looking forward to a great session, J.K. sir. Thank you so much. Over to you, Manoj, Dr. Manoj.
Thank you, Nishant. So good morning, one and all. Thanks for joining today. So now I call upon our first speaker and master of this Tnoa Connect series, Dr. J.K. Reddy, sir.
Thank you, Dr. Manoj. Thank you, President, and for giving this opportunity to enter, who is sponsoring this All Connect series. And it's a very unique program taken.
No, this is not Entod, it's Zavira.
Zavira, sorry. Last time. Sorry. I'm extremely sorry. Zavira is taking up this Connect series. They are very active and they are helping us in TNOA also in a big way. Now coming to our first talk, we selected only 6 talks with a small talks with a lot of discussion. So I want the moderators to criticize or to find the ways to how to improve our techniques in each way what we are presenting. The first my talk is on endo implant. What is an endo implant? This is endo implant is the prosthetic endothelium. Instead of the natural endothelium, we are trying to develop a artificial endothelium. It's a simple material, hydrophilic IOL material, which we are using for a long time. It's like a hydrophilic IOLs. This is from Contamac, UK-based company with a 25% water content, which you use for intraocular lenses. The only unique thing is you have to make it 50 microns thing. That's very, very critical, and it's very difficult. Maybe 5 microns this way or that way. That is the one, and 6 mm in diameter. And what endo implant is different from the international model is we incorporated 2 haptics on both sides to fix in the corneal stroma so it doesn't fall into the anterior chamber. The original inventor is EndoArt. This is from IAM, from Israel-based company, and from collaborated with Germany, David Apple Laboratories in Germany, and they are doing studies for some time. So we try to improve over this model. So the original endo implant is also EndoArt, an artificial endothelium, meaning 6 millimeters in diameter, and it's got a curvature and 50 microns thickness, and the same Contamac 25% water material they're using, and we are also using the same material. So what we did is we incorporated 2 haptics on both sides so that we can put them in the cornea, and this curvature will make the will match the corneal curvature. So this is the implant which we designed and made, and with the Indian companies. Now Excel Optics in Chennai are manufacturing for us, and this is a case of pseudophakic bullous keratopathy without a potential for vision. First few cases we did where there is no potential for good visual acuity. As usual, for any studies we do it, we make a pocket on both sides, both on the temporal and nasal side, as we are mostly doing temporal approach surgeries. And a 6 millimeters cornea is marked on the epithelium with a trephine. So we enter with a simple our phaco instruments, a tunnel of 2.8 millimeter size, and we put a trypan groove to stain the endothelium. Then we remove the endothelium in the center 6 millimeter area with a reverse Sinski. It's just normal Sinski. You turn it back and it becomes, this is used for scoring the endothelium and removing the endothelium. You can see that endothelium is very thick and stained, and it comes out very easily. Then the endo implant is kept on the other side and pulled with a micro forceps. This can be capsulorhexis forceps or any forceps, membrane peeling forceps, anything. And both these haptics will stay in the tunnels. And the optic will be in the center 6 millimeters where we remove endothelium, and we put a air to tamponade and remove the gap between and keep it attached. This is the technique. Very simple technique, can be practiced by any surgeon. You don't need a corneal specialist for this, trained person. And it is not organ transplant. So I think the government has no restriction in allowing only cornea trained person. Any person can do it, any ophthalmologist. So this is the post-operative. This is the pre-operative OCT showing folds and thickness cornea. This is the post-operative on day 2, showing the reduced thickness of the cornea and very uniform cornea. And these are the tunnels. You can see these tunnels, what we made. Through that, the haptic is going and sitting very snugly.
Slides are not moving,
gap.
JK.
Yeah, this.
We're still seeing the old video.
Okay, should not be problem. Here it is moving. Now it's not moved still.
Now we are seeing the.
Now we can see the OCT.
Yes, sir.
Yeah, it's moving.
Yeah, maybe some bandwidth problem somewhere. Now we can see the OCT. You know, this is the picture which shows that the endothelium is folds and thickening, and here the endothelium is it's uniform, and you can see the tunnel through which the haptics have gone inside, and the thickness also became uniform instead of irregular. So we did around 20-30 cases. So this is the pre-operative, this is the post-operative on day 2 with still air remaining. Then after that, this is the 1 month after post-operative, the cornea becomes much clear. This is initially we tried it in a no visual potential eyes with glaucoma and other comorbidities. And these are some more pictures. After some time, the first one is the contact lens, and this is the endo implant, which is snugly on the back side. And after manufacturer, though he says 50 microns, we want to test in OCT. We found that's almost around 50 microns plus or minus 10 within 60 microns thickness they are able to manufacture. And after some time, we started doing visually potentialized. This is one of the patients. He's having a macular dystrophy with endothelial dystrophy. This particular case we tried in topical anesthesia to see whether it's possible to do. So we marked central 6 millimeters cornea, and as usual made a side port and removed the endothelium of this patient with after putting viscoelastic. Usually I put viscoelastic in the anterior chamber, then remove the endothelium. You can do under air also. Somehow I had to learn the technique. Still, I have not tried much under the air. It looks under the air is better. So you can see nice endothelium. The endo implant here, unfortunately, video recording, you're not able to see like we saw in previous videos. We are pulling the implant into the anterior chamber. The pupil is constricted with the pilocarpine, and the implant is readjusted with the Sinski hook and viscoelastic aspirated with the Simcoe cannula through the side port, and we put air inside the anterior chamber. So, and this is the pre-operative, this is the post-operative. In the post-operative picture, you can see a little bit the signs of macular dystrophy, but central part is clear and visual acuity started improving in this patient. So this is the post OCT pictures where is a thickened epithelium. It's all removed. So we put this. You can see a bandage contact lens here, and the cornea is uniform in thickness in the central portion, improving the visual acuity and corneal clarity of this patient. And sometimes we had this gap, which was you can see here between the endothelium, between the donor implant and the cornea, there is a gap. What happened to these patients, I will explain later. And what happened is here by mistake, we implanted the endo implant in the reverse way. Over a period of time, you can see it became convex down. The implant is convex down. You can see nice clearly. So in this case, it failed. So we changed the, now we changed the new design. We changed the haptics. One side we put it straight, the other side to avoid confusion with a hook. So the hook always should face right side, and we are trying to improve. And still, this just received. We are waiting for the next volunteers who will be willing to take a chance and try. Thank you very much, and I invite the moderators for the comments.
Wonderful, wonderful.
Very nice, JK. How does this work actually? What is the mechanism?
See, we have not done any laboratory work as it is, because the laboratory work is available from the ION. And what they're saying is, in a bullous keratopathy, this is not suitable for cases without bullous keratopathy. For bullous keratopathy patients, where there is a increased permeability in the periphery, and the central 6 millimeters, it comes around 18 to 20 square millimeters. That nutrition can be supplemented by the peripheral 3 millimeters, which 4 we are not removing. So this is enough. That's what they have proven in the laboratory model. So they started doing, because the material they are using commonly available Contamac 25% water content. So it became very easy for us to just to replicate from the same material. If they could have developed their own material, then it would have become very difficult. We cannot do anything. Only difference what we are doing now is we are putting two haptics so that we can fix in the cornea. So it won't fall because it's not a natural material having endothelial pump. There is no pump, nothing here. It only restricts the flow of aqueous from the anterior chamber into the stroma. So it cannot, it takes some time to get fibrosed. So these haptics are holding this in the place.
Can I ask one question, SKR JK Reddy?
Yes, sir.
There's a really wonderful innovation. I was wondering, in DMEC and DSEG, there is an attachment of the tissue to the remaining stroma.
Yes, sir.
There is no space. Here, there is a likelihood of potential space, no, between the two. How do you take care of that?
The curvature will match that space, sir. The corneal curvature, we are taking a standard 6.3 millimeters posterior curve. So it is matching. It is, unless by mistake, like I did in 2 cases, by mistake we implant in the reverse way, then it is getting slowly, it is becoming reverse and it's failing. If you fix it in the proper way, that's what we rechanged the haptics so that we will have a clue which side is up. Then it is working very well. It's getting attached. The patients where it's successful, we had 3 patients which is successful. So there it is nicely attached and there's nice fibrous form and visual acuity nicely improved to around 618, 612 in spite of corneal opacities.
Why do you?
Yeah.
Yes, Bhaskar.
No, this is looking like a barrier effect. And being an artificial thing, do you think it's only for a stopgap arrangement till you get a good DMAC or something, or you want? Do you think this can survive long run also?
There are 2 issues, madam. Here, one is as far as in India is concerned, as far as I know, only Dr. Praveen from LVPA is got. He did a lot of work some 10-15 years back on a stromal implant and opacification of cornea. So they had, after 2 years, opacification of cornea around the implant after 2 years. But when they put a stromal implant in a normally functioning endothelium. but that is not anything stromal melt. They didn't had corneal melt or they didn't had stromal melt, but cornea became opacified around the in front of the implant. Here, the studies are only less than 2 years so far for us. So the ion company concept is, because it's a bullous keratopathy, you have enough flow of nutrients from surrounding cornea. So it should be good enough. That's only theoretical one. Practically, we have to wait and see. If it becomes opacifies, we have to go for transplant. If it doesn't, then it becomes a permanent. I hope I'm not seeing.
If I could ask a question, two questions. One, do you think there's any difference if you use this for, say, a Fuchs dystrophy versus a bullous keratopathy? Because if you are looking at nourishment in Fuchs, you're primarily looking at the central gut data causing issues. Your peripheral nourishment and even your peripheral cell count might actually be reasonable. Good. That was one. And the second was, since we are not dependent on the endothelial pump or anything for it to attach, do you think that you actually need to score and remove the Descemet's membrane, or you could just do it like a non-stripping unless the Descemet's is scarred, where you feel that that is going to affect the clarity of the cornea?
The first point is, in Fuchs and non-Fuchs, we had opinion, but right now we tried in this topical anesthesia, what I have shown last video, that is a sort of endothelial decompensation with a little bit macular dystrophy. So there is a component of decompensation in the periphery also. But the original inventor, EndoArt, he did all Fuchs dystrophy only.
That is what I was asking.
Only 1 or 2 cases he did one, but he has not given good vision, saying they tried in visually non-potential visual acuity. A 2-line improvement he has given, but we had a very good improvement. The other eye of the patient received DMEC with phaco and foldable IOL at the same sitting. Both eyes vision is same. Okay. This eye is 612, that eye is 612 now. Both matched same with a simple procedure. And that's always an argument. Only time will tell what's your point, whether it's a Fuchs or the. I feel that endothelium we had to remove, because already it is a bit compromised procedure. So this, if that produces more fibrosis of endothelium, even if it reduces the edema, that fibrosis can again affect the vision. So better to remove the endothelium. What we saw is, after 4 months, when you see in OCT, I missed that picture somewhere, it is there. I couldn't trace it. The implant, at the edges of the implant, there is a good attachment where we removed the Descemet's membrane, and it's nicely fitting and it's getting some amount of closure is happening.
Reddy Garu, what about the chance of dysfunctioning of your artificial endothelium, dysfunctioning or malfunctioning, rejection or something like that?
So it's a plastic, so no rejection. And and malfunctioning, as you said, only one problem is we are putting air tamponade. These hydrophilic lenses are known. Once we put an air tamponade, sometimes they go for opacification over a period of time. That is the known behavior. We don't know why they do like that. So that's why what we are doing is, after putting air tamponade, within few hours we are removing the air. We are not leaving the air for a long time like natural endothelium, because we are worried this material may go for opacification. So
what the cost already?
Yes, cost is still experimental products. It will not be very expensive, sir. It will be maximum 4,000, 3,000 rupees, like any intraocular lens.
Oh, that's fine. It's available now in India?
No, sir. We are making only for our R&D. We can supply, but we cannot afford to support the R&D. We can supply the lenses free of cost if somebody is interested.
Thank you.
Very good, man. JK.
Why do you need the air, JK? Why do you need the air? Because you don't. You're not depending on the. You're depending on the curvature primarily, no? So why exactly do you need the air?
Actually, you don't need the air. Any gap is there, viscoelastic left behind. We just want to tamponate for a few hours, and we have given a curvature. And we are putting a haptic also to press it against the cornea. So we can remove the, just after tamponade, few hours after, we can just remove it.
I have one question.
Nice.
Sir.
Yes, Manoj.
Sir, apart from the visual potential with this implant, how much permanent solution it will give for preventing recurrent bullae and other symptomatic effect for the patient?
Yes, very good question. From the peripheral area, they can be still, a bullae can form. And what the original inventor is doing is, he is putting them in a permanent bandage contact lens. None of their patients are away from bandage contact lens. They are permanently on bandage contact lens in the original inventor. But in our two or three cases where it is very successful, we removed the bandage contact lens. Right now, there are no peripheral bullae. Maybe when the peripheral endothelium, as Dr. Bhaskar has pointed out, if the peripheral endothelium still undergoes more degeneration and more loss, progressive conditions as in Fuchs, you may get bullae in future. Right now, they are all right. Only will time tell the answers. More people will do a few more cases.
Very nice.
There are
Congratulations.
no more questions. Can we move to the next speaker, sir?
Next session. Yes.
So now I request our second speaker for the Cornea Connect series, Dr. K. Siddharthan, the Chief Corneal Surgeon from Shankara Eye Hospital. He's a well-renowned corneal surgeon, as you all know. Sir, kindly share your screens.
Thank you, Siddharth.
Yes, sir. Good morning to one and all here. And I want to thank TNOA for inviting me to this wonderful session. So nice to see all my seniors, mentors, and all of them here. And I would like to talk on the optimal utilization of corneal tissue. I think this topic is nothing new. And I think it has been there for so many years. But I think COVID has given us a awakening call to reconsider what are the techniques to really optimally utilize. I think when COVID had happened, I think the corneal surgeons were the worst affected because the eye banking completely stopped. And I think even the government had stopped because of the infective nature. We could not collect eyes. And that was a real time when people we were having more perforations, the graft rejections were happening more because of less follow-up due to lockdown and all these effects. So coming to the history, I think most of us know that cornea, I think all the layers now can be replaced. For example, the corneal epithelium can be used for slit. The Bowman's layer is now transplanted for keratoconus, and all these three layers along with epithelium, Bowman's, and the stroma is used for DALK, and even for keratoconus patients, the stroma is given for augmentation. The Descemet's membrane can be done for the DSAC or DMAC, and the cells alone can be done for cell culture. So cornea, so much forgiving that we can layer by layer we can use, but still very few people use the entire cornea for all the procedures. When we do a DALK, we discard the DM. When we do a DM, we discard the stroma. So I think now, even though the pandemic is almost gone and all these techniques are, all the eyes we are able to get, I think still we should be able to refine our techniques. So I think this one, as this splitting cornea into two, has been there for so many years. That's nothing new for all our corneal surgeons. We used to use a microkeratome to cut the cornea, and then we use the posterior lamella for the DSAC and the anterior lamella for anterior stromal pathologies. But microkeratome is very expensive. Not that every corneal surgeon can get access. It's only the institutions can do. So about even before pandemic started, about 2-3 years back, when I started doing DMAC, I used to use the same tissue for DALK and DMAC. For DALK means it's a pure keratoconus patient, and then a patient with an endothelial problem. So this was very useful because I did not need any special instruments, and did around a few 23 patients of, we did more, but just published this 23 patients of DALK and 23 patients of DMAC. It really came out very well. The only thing in this, when I did the initial study, was the first 10 patients whom I did DALK and DMAC, the DALK did very well, but the DMAC, out of that 10 patients, 4, 5 failed because it took a little bit of time for me to really get used to the technique of transferring the DM from the A grade tissue to a B grade tissue. So this is how I did. Like what I did is like you see here, I have stripped the DM halfway, marked the DM is marked. This is an A grade tissue, and the right side, this one is a B grade tissue where we get so plenty of B grade tissues now. So the DM is stripped off now. And here, after removing 360-degree the DM, I'll be transferring it into the B grade tissue, so that you see here, this is the B grade tissue with a good quality donor DM, and this is a clear-cut 40-45-year-old tissue with a good stroma. So this will be ready for DALK, and this will be ready for DMAC. So when I published this, the many questions which I asked, which was repeatedly asked, was how is this possible? How can a surgeon do both together? Will the time will be a big factor or anything? But as you all know that as we do, DALK might take 1 to 2 hours and DMAC might take another half an hour. So 3 to 4 hours we can finish the surgery. With a single eye, we can use for 2 patients. Going a step ahead, during the COVID times, we used to preserve these tissues. So the same way, rather than using for 2, we started using it for 4 patients also. For the same, this one is a patient with a keratoconus, a DALK was done. And here the a patient with Fuchs, DMAC was done. And this was a patient with scleral bleb, the sclera was used. And here a patient with a Stevens-Johnson syndrome, a slet was used. And these were all about a year of post-op pictures. All of them were doing well. We can see a very good cell count in these in the DMAC. And all these patients really, now it's almost more than 2 years and they're all doing very well. So I'll just share you the techniques, how it is being done, how it was done. This is from A grade tissue. The DM, I'll be stripping the DM here with the scuba technique. So as you know, we don't need a microkeratome or anything as previously used. So once DMAC has come, it has made our life really simple. So here I just make a superficial mark with a 10 mm and I don't really puncture the DM. And here strip it into the half, mark the DM. Here this is the B grade tissue where the DM strips off very easily. So now here I will remove the DM 360-degree from its complete attachment and then transfer it into the same. Only here I have to put it in reverse, meaning that the L mark should be reversed here because the endothelium is up. This took a little bit time for the transfer and all these things to understand. That's why I had a little bit failures in the first 10 cases. And after that, there was no looking back. Almost all the cases were doing well. Here the DM is punched. Sorry, the stroma is punched. And the DALK is already, I have finished the DALK. And once I finish the DALK, I make it back. I do the strip DM removal because once the DALK is completed, patient is under GA. So it is better to first finish the DALK here. So the DM, I store it in the MK over the same solution, cortisol. And then once the surgery is over, here I punch the tissue. As you know, the DM is actually already stripped. It hardly takes 5 to 10 minutes to prepare this tissue. And once the patient is ready, we can transfer it into the patient. So here, a single tissue can be very easily used for both, and it gives the best anatomical perfect fitting for a DALK in a keratoconus and for a DMAC for any endothelial disorders. I think this is a very good technique, and air is put and it's attached. So this, apart from this, we can use it for many other things. The DMAC tissue, as I showed you before, that we transfer to another tissue here. We sometimes, most of us use it for punching into a small 3 mm punch. You see here, we use this. I think most of the people who are doing DMAC, they use a small punch here to mark the DM. So this small punch, once you use the small punch, can be used for any of your patch grafts. So you usually store it, and we can use it for simple patch grafts. So this, we were doing it during the COVID times. We used to discard all these tissues before. Then we started storing this in glycerine, and then again using whenever it was necessary during the COVID times. But still, even now, I think we can use in institutions where you get so many cases. I think optimal utilization of tissue, we can have all these ideas so that whenever we have these tissues stored, we can use it for even this. And again, for PUK, nowadays what we is the same. You can see a DMAC tissue here. I have used. I've stored this tissue. So what we do in PUK is after doing a conjunctival resection, if there is a gross thinning, we just don't suture it with a AMG. We use around maybe 150 to 100 micron of cornea. We suture it. I think this is many people use whenever there is a perforation, we use for crescent graft. But here what we are doing is, we are even for about 70% or 60% thinning, we like to replace the stroma, because this tissue is going to go waste, and patient is anyway going to be under immunosuppressive when steroid drops, and we fix it with glue. And also here another case where in an intrastromal pocket is created, and for cases of keratoconus, the stroma can be used as a stromal augmentation can be used here. So here, after using a DMAC, after this this tissue can be cut into whatever size you want, and then in an artificial antechamber or in a microkeratome can be cut, and it can be filled into the stromal pocket for case of keratoconus. And in case of PMD, I think I have not done many cases. Dr. J.K. Reddy regularly does this procedure where you can see here inferior thinning, and this is UC and PKP used tissue. We use the periphery of the tissue. You can see here we mark, rather than just throwing this tissue out. We use it for the PMD stromal augmentation. It's trimmed as much as possible, because we are going to put it into the periphery. It's better to take the periphery of the cornea, where we generally throw it off. So this, we actually prepare it very well, make it as much thin as possible. This does not much improve your vision, but it gives a good stability, because these patients are at always risk of rupture, or there's always some disturbance in that area. So we generally do this. And I know Dr. SKR is a pioneer in this, and I think he'll be talking about this later in the talk. So there are many methods where we can really use these tissues. It's just that this COVID made us realize that we should use all these tissues. We should not waste. Even in limbal dermoid cases, rather than just removing the limb, what we do is around 75 to 100 microns of the anterior stroma I use. You see here, I make a small groove, all 360 degrees. And then what happens is, once you put the tissue, it gives a little bit of strength, rather than it becoming a depression there. It gives a regular smooth surface there. Here again, a tissue, you can make a 100 micron mark here, just a superficial layer, remove, and you can use it. This tissue you can use for BSAC or whatever you want. You can use this tissue, or for SLET or whatever, you can use this tissue. So this is again a 100 micron flap taken, and then you put it over the donor graft and trimmed and sutured. So these are many methods where I think all of us, instead of throwing the tissue, we can do it. So going one step ahead, 5-in-1, we did a few cases where sclera was used by our retinal colleagues for retinal buckling, like scleral, when there was a detachment they were using. So actually we could do even 5 patients for one tissue, which is really will be really great if everybody can follow and do this. One challenge which I want to tell everybody is this. It made me realize, because when I published, this also was a question. How did you manage? How did you get 5 patients when you get a tissue? How did you get 5 patients? So that is very important, because in the eye bank, you should segregate the patient list into cluster segments. Means that when you have a DALK, segregate DALK 1, 2, 3 like that, DMAC 1, 2, 3, or scleral patients like that. You make them into a component corneal surgery patients. You divide like that. Don't keep a complete waiting list. That is very important. So when you get a tissue, call the number 1 waiting list from your for the DALK list, DMAC list. you want to call for a patch graft or whatever PUK patient, make a proper segregation of list is very, very important. So that eye bank role is very, very important here. It's not very easy to call patients, 4-5 patients at one time. Also, care should be taken in documentation of the donor, because for one patient, for one eye, you are using 5 patients. So you should have a proper record. If there is no proper record, it will become a problem. If there is any issues, you may not be able to backtrace. So in our eye bank in Shankara, we segregate like that. That's how we do according to the diagnosis. So it's very easy. So after assessing the quality, the first patient in each waiting list is called for the next day. So there's no confusion. Another thing is also the fellow donor cornea. We generally use it for full thickness graft, because one eye we use it like this for multiple component, the other eye for full thickness, because we have to give priority to everybody, because full thickness patients cannot just keep waiting. So this is also one thing which we, all of us as a surgeon, as corneal surgeons, we should also keep it in mind. Thank you.
Incredible talk, Siddharth.
Yes, sir. Thank you, sir.
Incredible. Fantastic.
Lovely talk, Siddharth.
Yes,
Just
yes.
a couple of questions. See, when you were preparing the DMEC tissue, you have actually stained the tissue before you shifted to the therapeutic grade tissue. So if you're staining it or marking it, if you know that your DALC is say 8.5 or 9, then you actually don't need to shift it. You can actually punch it and store the tissue directly instead of shifting it. Could that be an option? Because when what I have felt is when I take it out and I put it on the thing, I had a tough time unfolding it on that tissue without traumatizing it. Like you said, your first few cases, you had a higher failure rate, because I've only done a couple of patients, but I've had a tough time trying to unfold it and get it oriented in the correct direction. And I've also had higher endothelial loss in my 3 cases that I was able to use the same tissue.
Yes, Bhaskar. See, the thing is, as you felt the same 10 cases, I had a problem. Only issue is, Bhaskar, if you have only one tissue, okay, and you're doing a DALC, you remove the history. As you say, you can even do DMEC first. You can remove that 8.5 you mark, you can do it. But in case you have a problem in your DALC, that is the biggest concern. If you have a perforation, if something happens, then you are not having a tissue. That is the only issue. Otherwise, as you're telling now, I think I do like this. Dr. JK does like what you say. He will punch, he will take the DM, he'll do the DMEC first, like as you are telling. That's how he does. But I generally tend to do this because if anything happens in DALC, then that's an issue. So that's the only thing. Otherwise, your point is well taken.
And there were a couple of publications where they have just kept a contact lens adjacent to the tissue and kind of slipped it across and then punched it and marked it. The only some concern sometimes I have when you just fold it, if there's a little bit of fluid on the bed, the ink tends to smudge. Then it becomes difficult when we have to do the DMEC with a smudged P or an S or a L.
Yeah. So that is there. That's what I told you. After 10 cases, it became really easy, but first 10 was really problematic. As you said, initially I tried contact lens also. I think Dr. Basak has published, and I think he's got an award also for that. We tried in contact lens, but it was a little bit tough in a contact lens to.
And the other thing is sometimes we might not have all the patients on the same day. So it's important to know what the media is. So if it is an MK that you have done and you're planning to call the DMEC the next day or use it for a tissue, you will have to then think whether you want to shift it to Optisol or you want to shift it to glycerine, because you don't want the time frame in that media too. So that's something which the eye bank has to be very particular about, especially when you start doing multiple patients with the same tissue.
Yes, Bhaskar. That's what DALC and DMEC is done. As you say, other things, if the patient delays, then it's stored. We generally store in cortisol only.
Yes.
So generally, we keep the tissue in cortisol for the other procedures. But DALC and DMEC, we do it on the same day.
Very nice, Siddharth. I think just one word of caution. I mean, it's nice we can do this, but occasionally we do get infections. So if you have an infected tissue, then we're going to have 5 infections rather than 1.
Yes,
and with despite all our eye banking protocols, it's never a sterile tissue. So you have to be a little careful about only that concept, I think. Yes, otherwise, very nice. Yeah.
Yes,
I mean, the only thing is, most of the time, at least the infections that you've had are with corneal tissues have been with patients on ventilators for a long period of time or road traffic accidents. So those kind of tissues, maybe you would want to be a little bit careful when you cluster more than one patient with those tissues.
Yes, Bhaskar. That's a valid point.
That I just have a question for how do you get all the 4 patients lined up at the same time? So it's very difficult, no?
So that's what we have because there are patients, so many patients waiting, sir. Actually, we need tissues. As you say, that's what, sir. Initially, it was really tough, but we have now in our iBank segregated like that. So we keep the patients who are waiting that, call them and keep them informed. Like you are the next. So be please ready in a week or 10 days. We'll call you. So most of them they are okay, sir. Most of them they are. But we call and inform them. So they are about a week ready.
Good, fantastic.
Thank you.
Yeah. Manoj?
Yes, sir. Thank you, Siddharthan, sir. So we'll now move on to the third talk for the session. I welcome Dr. Bhaskar Srinivasan, sir. He is the HOD of Shankar Nethralaya Ocular Surface Disorders. Kindly share the screen, sir.
Yeah. Good afternoon. Just to correct, there is no HOD in Ocular Surface Clinic. We come under the domain of Cornea department at this point of time. So I'll just start my screen share. Yeah. So I would like to thank Tnoa and Dr. JK Reddy for giving me the opportunity. So I will be covering something about the Asia Dry Eye classification of tear film oriented diagnosis and tear film oriented therapy, which basically focuses on the role of fluorescein and how we can assess the tear film dynamics based just on a simple test. No financial disclosures here. And this part of the study is from the Asia Dry Eye Society's publication. And I would like to also acknowledge that the original videos were given to me by Santen for one of their presentations. So when you look at the definition of dry eye according to the Asia Dry Eye Society, it's a very simple definition which says it's a multifactorial disease which is characterized by an unstable tear film, and this causes symptoms, and this can be potentially accompanied by ocular surface damage. When you compare this with the DUCE 2 definition, the DUCE 2 definition is a lot more inclusive because it talks about, in addition, about the hyperosmolarity, ocular surface inflammation. So DUCE 2 talks about a lot about the pathophysiology of the disease itself, along with defining the disease. Asia Dry Eye Society definition is more practical in terms of, yes, there are symptoms, yes, the tear film is unstable, and the patient is classified as having dry eye. That's the basic difference between both the definitions. So this is in a nutshell, it tells you, okay, you need to look at patient symptoms, you need to look at the tear film breakup time, and then that gives you the diagnosis of dry eye. And for this, the most important test to diagnose dry eye is the tear film assessment. So when you're looking at tear film assessment, you have certain components of tears. So it could be either a mucin deficiency, an aqueous deficiency, or a lipid deficiency. And you could have dynamic factors in terms of blink, like an increased blink in blepharospasm or a lag of thalmus. All this will also affect the distribution of tears on the ocular surface. And this will also come under the domain of dry eye or tear film instability. So when you're again comparing both with respect to the diagnostic criteria, the DUCE 2 speaks of symptom questionnaire. Then it speaks of 3 basic tests. It speaks about a tear breakup time, which ideally, according to it, is a non-invasive breakup time of less than 10 seconds. It speaks of tear osmolarity more than 308 milliosmoles, and it speaks of ocular surface staining. Now, again, when you look at tear film breakup, if you're looking at a non-invasive breakup, you will need to have specific equipment to look at it, especially something like a topographer, which gives you a breakup spot. If you're looking at osmolarity, there's again a cost component in getting the machine, getting the chips, which adds an extra cost to the patient that you would be evaluating. Ocular surface damage, we all check anyway with a fluorescein stain, which is part of the AIDS guideline also. So the Asia Dry Eye looks at tear breakup, but here the cutoff value is 5 seconds. And it says that if it is less than 5 seconds, definitely the tear is unstable. And it also looks at the pattern of break, the time of the break, and then tries to divide the dry eye into various types, whether it is aqueous deficient, whether it is lipid deficient, whether it is mucin deficient. The DUCE doesn't specifically look at categorizing it, it just tells you that yes, you can have ATD, you can have evaporative dry eye, and you can have most of the patients falling somewhere in between based on your tear meniscus height or your non-invasive breakup time and osmolarity and surface staining. So when you're looking at tear film stability, you are looking at, ideally when you look at the definition of tear breakup, you're looking at the first random spot of break. So you have to put a drop of fluorescein, which normally should be the same amount. Obviously, we cannot use a micropipette in all our patients. So if you're putting a drop of fluorescein from the fluorescein strip, make sure that you shake that strip a couple of times, put instead only one drop on the fluorescein strip, shake it, and then just dab it in the lower fornix so that you are reasonably consistent with the amount of fluorescein that you are placing on the surface. Because if you put too much of fluorescein or you put too less of fluorescein, again, the value that you get will change. You're supposed to look at the first random spot. So you ask the patient to blink a couple of times and then see the breakup time. Again, you would ideally need a stopwatch to kind of calculate your breakup, or you can mentally keep calculating. But mentally, if you keep calculating, sometimes you can be fast, sometimes you can be slow. The other thing is, if the breakup always happens at the same spot, then there is something wrong with the epithelium. So it could just be something like EBMD or something like a bulle, which is why you're getting a negative staining faster in that consistent area. And if you have any of those, you have to look more closely at the cornea to see if there's any other problem in the ocular surface. So the Asia Dry Eye gave these patterns of fluorescein breakup. So it said something called as an area pattern of break, which basically means that there's a diffuse staining on the surface. And as soon as you blink, you're almost seeing a breakup spot. You have something called as a line break, in which as the lid moves up, as the tear film moves up, you will see linear break pattern happening from inferior to the superior portion of your ocular surface. You have something called a spot break, dimple break, which are more suggestive of mucin deficiencies. And you have the random break, which is more suggestive of evaporative deficiency or meibomian gland dysfunction. We'll come to videos of it. So how does the fluorescein breakup pattern help us? Because it helps us to classify the dry eye based on whether it is ATD, whether it is mucin deficiency, or it is an MGD. And once you know what is the primary factor, you can plan your treatment accordingly. If it's an ATD, you might want to give just lubricants. If it is a lipid deficiency, you might want to in fact think of the more recent advances in terms of LipiFlow or IPL to improve the patient comfort. So this is again a nutshell where the pictures are shown. So when you're looking at an area break and it is very, very severe in terms of the figure in this area, it shows that there is significant ATD, and this breakup and this pattern is seen immediately after a blink. When you look at the bottom figure, when you see a line break, it's more suggestive of a milder form of aqueous tear deficiency. A spot break and a dimple break are more suggestive of a mucin deficiency, where there's some issue with either the surface mucin on the ocular surface or the soluble mucin in the tears, which is why you get this pattern. This spot break is something that the Japanese specifically mention a lot with respect to short breakup kind of a dry eye, because these are normally seen in younger patients who are very, very symptomatic. If you look at the surface, you don't see any staining. You do a Schirmer's, the Schirmer's value is good, but these patients are generally going to be very, very symptomatic. And that they claim is because there is a deficiency of either the soluble mucin or the surface mucin, which prevents the tears from coating the ocular surface well, and that is why they are symptomatic. The random breakup, when you're looking at an evaporative dry eye, basically means that once you blink, the tear film first stabilizes. So first the tear film forms, and then after a few seconds, once the tear movement stops, you should start seeing breakup of the tear. So that is what is an evaporative breakup. So if you're looking at an MGD patient, you would probably see the tear film move up. You will see the tear film stabilize, and then you will see random areas. Again, here the important word is random. If you're talking about an MGD kind of a dry eye, you will not have the breakup happening consistently in one area. You will have random spots occurring in the interpalpebral area. Whereas you're talking of a decreased wettability dry eye, you will normally see either a pattern in that same area which involves surface mucin deficiencies, or it would involve multiple areas, but it will kind of be like a spot break where you will see it immediately after the blink. So this is the video. This is from the official video. So you can see there's hardly any movement of the fluorescein as the eye moves up, as the upper lid moves up. There's a diffuse staining. It's almost an instantaneous blink. It also tells us that the tear meniscus height here is significantly low. All these factors, just as a glance, tells you that yes, this patient has severe ATD. Now this is a line break where you can see the tear film moving up, and then you can see these vertical streaks of line coming up from the lower portion, indicating there is aqueous tear deficiency, and the amount of aqueous is not sufficient to coat the surface, so you start having a breakup of the tear film. This is what is called as a dimple break, where you will start seeing a breakup of the tears in this area, more like a wave-like pattern here. You can see random spots happening here, and then you tend to have a wave-like pattern which forms in the center. This, according to the Asia dry eye, is suggestive of mucin deficiency. And this is what they claim as spot break, which is very classically seen in youngsters, patients who work on the system for a long period of time, and patients who are generally very, very symptomatic, but you don't see a staining on the ocular surface. And this is what you would ideally get in evaporative breakup. You're seeing the tear film is formed, it's stable now, and then you see random spots occurring. So you get a tear film formed, it is stable, and then after a couple of seconds, you start seeing the breakup of the tear film, which happens. So it's important when you're looking at a tear film to know, one, what is the tear meniscus height? Two, how much of the fluorescein moves up as the patient blinks? Three, what is the time of breakup? Four, what is the area of breakup? Five, what is the pattern of breakup? This to a large extent gives you an idea whether you're dealing with an aqueous tear deficiency or you're dealing with a mucin or a lipid deficiency. The problem is ATD becomes easier to identify. Mucin and evaporative dry eye, to a certain extent, there is a bit of an overlap. And to a large extent, none of the dry eye patterns are uniformly consistent. ATD becomes consistent, but you will always have an ATD with an MGD component or with a mucin deficiency. So even in the pattern of breakup, you can sometimes have a mixture of breaks, which I will share later. So this is some of the videos that we collected at SN, where again, you can see tear meniscus height is low. And once the eye is blinking, you hardly see any fluorescein move up as the eye is blinked. And the surface is already staining significantly. So you know just by looking at it that yes, you're dealing with an aqueous tear deficiency, which is severe. Another patient with an area break, but less severe than the previous picture. Again, you see minimal movement of the fluorescein up, but as soon as the lid moves, you're already seeing the stained area, you're already seeing the breakup pattern which happens here. So this also classifies as area break. This is less severe spot break, but you can see as soon as you're blinking, you are seeing these areas of fluorescein which is broken up. So the tear film is not coating, even though the patient is blinking, the tear film is not spreading uniformly on the ocular surface, and that is responsible for the symptoms that the patient perceives. And this, like I said, you might have multiple patterns in the same patient. So this is a patient with ATD. You can now see a spot break, and then it forms as a line, and then it forms a dimple. And you again have a dimple forming superiorly also. So unfortunately for us, we can't always segregate the patient as aqueous deficiency or mebum deficiency or lipid deficiency, but looking at the pattern gives us an idea which component plays the maximum role in that particular patient, and we can try to address the component better. So when you have issues like a keratinized surface, again, it's like a spot break because the tear film cannot coat the surface, and you see this almost instantaneous flowing of fluorescein away from the keratinized area. So this is a type of severe spot break or decreased wettability dry eye. And this is basically a random break where you're seeing the fluorescein move up, the tear film is stable, and then you're seeing random spots occurring at different areas. So this is classical of what you would see in an evaporative dry eye as such, where you're looking at the mebum quality. Again, if you have access to equipments, you can do a lipid layer thickness, you can do a mebography, but just looking at the tear pattern, expressing the mebum quality by pressing on the lids gives you an idea whether, and looking at the timing of the break gives you an idea whether the patient has mebumin gland dysfunction, and then you can decide whether you want to offer the patient the option of LipiFlow or IPL as such. And one more thing which was not covered specifically in the Asia Dry was the lid dynamics. So if you have a patient with an incomplete blink like this, obviously the tears are not going to coat the surface. Yes, he has already a very poor tear film, plus he has an incomplete blink, which makes the tear film unstable. So when you're looking at treatment of dry eye based on the tear film pattern, the Japanese have access to multiple molecules, which we do not have. So for them, if it is very severe, you have the option of retention of fluid with plugs. If it is mild to moderate, you would want to supplement the tear fluid. If it is decreased wettability, you supplement mucin. And if it is random break or evaporative dry, you supplement lipid or fluid or mucin based on the component of which is the most severe in that particular patient. So for retention of patient, you have the option of punctal plugs or preservative-free tears. For mild to moderate, they have the option of diclofosol or sodium hyaluronate, which is the primary molecule that is being used in Japan. For decreased wettability, diclofosol plays a very important role by increasing the surface mucins also. And for evaporative dry eye, again, sodium hyaluronate and diclofosol works well. So for the Japanese, it's very easy because diclofosol works well across all the three spectrums. So they can actually start all patients on diclofosol. Unfortunately, we do not have the luxury of having that molecule with us at this point of time. So what do we do at present is, for a very severe dry eye, we'll probably be looking at plugs or cautery, preservative-free tears, gels, ointments, or the use of a scleral contact lens. When you are mild to moderate, you have n number of lubricating drops, whether PG, PEG, CMC, HPMC, sodium hyaluronate, all of which will fit the bill for the patient. If you're looking at a decreased wettability, even though rebepamide in terms of fine tears was available in India, we did not have a very great experience with it. Patients were not able to tolerate it as well. So we do not use it on a regular basis. So we are probably looking at something like a PEG, which coats the surface better, or sodium hyaluronate, which stays on the surface for a slightly longer period of time. When you're looking at an evaporative dry eye, again, we don't have lipid containing drops at this point of time. I believe one company is coming out with a lipid based molecule soon. So that would be an option for us to try and see if that makes it better for the patients. But at this point of time, it will primarily be either a sodium hyaluronate based molecule or a PEG with HP-GUR, which will try to increase the tear breakup time in these patients and make them more comfortable. So in a nutshell, when you're looking at the lipid layer deficiency, you're probably looking at warm compresses, you're looking at either diclofosol when it's available in India, or you're looking at either a PEG or sodium hyaluronate. You're looking at either IPL or LipiFlow to improve the lipid layer status. If you're looking at a mucin or aqueous deficiency, in India, you're probably looking at artificial tears which are retained on the surface for a longer period of time, such as sodium hyaluronate or PEG. If you're looking at any epithelial issues that the patient has, you could even look at autologous serum, but then you have to reconstitute that, and you're always worried about contamination of these molecules. If you have ocular surface inflammation, then there is a definite role for steroids, and in certain patients, a topical cyclosporin seems to work well. So the difficulties that we have with the Asia Dry Eye classification is, even though the aqueous tear deficiency is very simple part, the spot and the random breaks are a little bit difficult to appreciate. We cannot segregate our patients primarily just based on this, because we cannot selectively use mucin medications which are not available in India at this point of time. So we still have to give people a combination of lubricants that we would normally give for any patient. But it is important to know which factor is playing an important role in the patient, so that we can have a fairly decent conversation with the patient and monitor his comfort level. So it helps us understand the tear film dynamics better. It's a very inexpensive way of diagnosing and categorizing dry eye using just a fluorescein strip, and it's easily and universally available for all ophthalmologists. So I would definitely encourage participants who are there in this webinar to go ahead, stain all patients, try to look at the fluorescein pattern and breakup, and enhance the care that they offer their patients. Thank you.
Very nice, Bhaskar.
Thank you, sir.
Very informative.
The DUSE 2 is very confusing. DUSE 1 itself is confused us, and DUSE 2 became almost impossible to practice. They almost, I think, sat for 15 days, 100 people across the world, and wrote DUSE 2 so that there are 100 people confusing you at a single point of time. It became so you cannot have 100 teachers and one student. it should be 100 students and one teacher. So that's I found this what Bhaskar has presented very interesting, and it very simple and a clinical tool. Just takes 2 more minutes than extra time than the regular. At least we can start. DUSE-2 is almost impossible to start in clinical practice.
The problem with DUSE-2 is it's significantly machine based. One, even in the machine, your values are not always consistent. So if you look at TMH, if you have a conjunctivochalasis, the machine will actually give you a higher value. Only when you actually see the patient, you realize that the tear film is broken by the conjunctival fold. So the actual tear film is much lesser. Even if you look at meibography, which people are using right, left, and center nowadays, it only tells you whether what is the gland loss which is there, but it doesn't uniformly correlate. The lipid layer thickness also doesn't uniformly correlate with what you are clinically seeing. So for a dry eye patient, investigations can be an add-on. Your clinical evaluation of the fluorescein pattern on the surface and the tear movement on the surface plays a very important role in understanding how the tear is coating the ocular surface. We've started looking at lacrimal gland flow also recently over the last year or so, trying to see if that correlates with the ATD component. Still early days, but again, if you are getting a very variable Schirmer, sometimes looking at the lacrimal gland volume and the amount of it which is flowing out, we try to see if there is some sync between what you are seeing with the Schirmers and what you're seeing with the lacrimal gland flow, even though that is probably it will come with the reflex tearing and there is some bias to it, but at least you start evaluating it, it gives you a better picture.
Can I ask a question, Bhaskar and SKR and other panelists, moderators? So in a nutshell, can you tell Bhaskar which to use what?
For
not to use for which condition?
Yeah, so if you're looking at an aqueous tear deficiency, any of the lubricating drops are fine.
HPMC.
Yeah, CMC, HPMC, EPEG. But if your frequency is high, I mean, if the patient is using the drops more than 8 times, 7 to 8 times, then I would want to add a gel-based formulation so that the number of times that he is using it reduces. If even after that, he still has to use the drops more than 6 to 8 times, I might be looking at tear conservation strategies as such. If you are dealing with a primarily MGD kind of a patient, I basically would want to advise the lid hygiene as such as the first step. Reassess the patient a couple of months down the line. Since we have access to lip view, I would get a lipid layer thickness done. If the patient is comfortable with the lubricating drop here, I would probably be looking at the PEG PG or a sodium hyaluronate more, because the breakup is a little bit more delayed with these molecules on the surface as compared to just a CMC or an HPMC based molecule as such. And if the patient is not comfortable, then I would probably look at the option of an IPL or a LipiFlow for that patient. Mucin deficiency, we don't really, after this definition of dry eye based on the Asia Dry, we've started looking at it, but we don't really treat it specifically at this point of time, because repepamide that was available is not was not tolerated. The fine tears was not as comfortable for patients that we were using it. So if there's not much of staining on the surface, the breakup is slightly faster, I would still go ahead with a PEG PG or a sodium hyaluronate as a molecule. So to a large extent, PEG PG would be a molecule for evaporative and for mucin deficiency and for mild to moderate ATD. For very severe ATD, the sodium hyaluronate molecules don't seem to be working as well. You will have to add on a CMC or an HPMC just to keep the surface wet.
If I may add, Bhaskar, of course, this is very, very important, where you highlighted the importance of clinical examination rather than depending on some machine. One thing, especially for the juniors. And another thing, you also have to spend a lot of time in taking history in these patients to understand their lifestyle and which actually causes the trigger, all those things. And other components also you have to look at when they are symptomatic, the associated allergic conditions or Demodex conditions, all these things also you have to look at. And one more thing, though we are classifying like this and giving this molecule, that molecule, we have to keep in mind there will be an associated ocular surface inflammation in all these patients after a certain stage. Maybe initially all these things will work, and later there will be a component of ocular surface inflammation, which also has to be addressed along with the molecules, what we are choosing from the artificial tears, we have to go for one of the cyclosporine or a pulse steroid therapy or associated systemic therapy. All these things we have to keep in mind.
Okay. Thank you, Bhaskar sir, for a wonderful talk. So next we'll move on to our next talk of the session. He doesn't need any formal introduction. One and only Dr. S.K. Rao. Sir, kindly we invite you to the presentation.
Thank you, Manoj, and thank you, Tnoa, Mohan, and JK for the invitation. Nice to see all of you on a Sunday morning. Basically, JK wanted me to speak about pellucid marginal degeneration. I'm not really sure what's new in it. In fact, there's two things. He does the augmentation. I don't. I do more of a subtraction therapy for pellucid. So it's really an update. It's not really something really dramatically new about this condition. So I think as far as the diagnosis is concerned, for me, these are my red flags. If I see somebody who has a changing refraction in his 30s and onwards, and if I see an extensive astigmatism in the refraction without commensurate myopia, these help me differentiate it from a keratoconus, because keratoconus usually starts stabilizing in the 30s. These people start changing a decade or so earlier, and it's almost always a myopic astigmatism in these people. 30 is still young. I'm now 57, so 30 is very young. And in these people, normally we naturally see with the rule astigmatism. So if you see somebody in his 30s starting a bit of an astigmatism, particularly if it is against the rule, that should be obviously a red flag. And then the bow tie starts to bend at the two edges. And these are just pictures I captured from the net. This is against the rule astigmatism. You see the edges of the bow tie on both sides. Whereas in a pellucid, we have what we call the crab claw, or the butterfly wing, or whatever you want to call it, a loop cylinder, if you will. So if you just casually look at it, it looks like it's just an against the rule, but the two edges will bend down. And if you have a good topographer which can match even the periphery, if it can capture that, you'll see these two things meeting in the bottom and forming a loop. The thing that differentiates it for me from keratoconus is that in my experience with PMD, it does not stabilize ever. It relentlessly progresses. Unlike in keratoconus, where we say that after about 10 to 15 years, about 35 or so, natural cross-linking works, and it basically stops the cone from progressing. This does not happen in a pellucid. And the relentless progression and thinning result in the loss of tectonic integrity. And in this particular situation, I do not wait for documentation. I don't need, like in a keratoconus, sometimes you want to document the progression and then you would treat. In these people, I don't wait, I will treat, because in my experience, like classic ectasia, the chance of it stopping by itself or naturally is virtually nil. Why does this happen? I'm not really sure, because they see that the thinning is here and it's a protrusion of the natural, the normal thickness cornea above it, which gives you this fat man's belly or a tabletop protrusion, as opposed to keratoconus, where the protrusion is actually in the thin part. I think that's the difference, and which is why here some amount of natural cross-linking which occurs with age will allow the cone to stabilize, whereas here that does not happen, because what is protruding is not the thin part, but it's the normal cornea above the thin part. When it comes to management, obviously these are the key things. We need to visually rehabilitate the patient. We need to stabilize the progression of the corneal protrusion. We need to restore the tectonic integrity in people who come to us late. But often whatever you do in terms of treatment will combine all of these three. You have to look at all three anyway. And occasionally, like in this patient, you can have a combination of a keratoconus and a pellucid. And sometimes I've seen people with a PMD in one eye and a keratoconus in the other eye. Just re-emphasizing that this is just a spectrum of corneal ectatic disorders, which we don't understand all that well as yet. And which manifestation you see depends on whatever genetic combination that particular manifests. In the early stages, they do get by with spectacles, and sometimes you can try these special contact lenses like the large diameter rose scale lenses that are present for irregular corneas. But if it goes beyond the moderate stage, then the lens will not sit, and then you will need a sterile contact lens to help them. And there are surgical modalities as well. So this is somebody with a mild PMD, where you can actually use a large diameter irregular cornea rose scale lens, and this patient did very well. You can see that the lens edge, even though it's an RGP lens system, comes almost up to the corneal limbus, but these people can see quite well. But once it goes to the moderate stage, this will not work, and then you need to put a scleral lens, because the bowing is here, so the lens tends to slip off if you put a small diameter lens, standard Rosquet system or something like that. So you need a scleral lens to vault this. Would be very cautious in offering a scleral lens system in the extensive or the very advanced PMDs, because they have almost paper thin corneas here. And then the very act of fitting these large lenses in and out every day, twice, 3 times a day, we can actually hurt the cornea more. Stabilization obviously is cross-linking, and there's a recent review which says that despite the limited experience with PMD, unlike what we have with keratoconus, that cross-linking is an effective modality. But what you must remember is that you must protect the central cornea, which is actually the normal thickness cornea, which is not the one at fault. You must protect the limbus because you're going way out to the periphery with your ultraviolet radiation. But the protocol for me, at least, is the same. I use the accelerated protocol for my keratoconics, and I use the same accelerated protocol for my PMDs. What I've learned, however, is to make sure that I shield the central cornea and allow the circular beam that you're using from your UXL machine to basically only irradiate the peripheral crescent and not the central cornea. Otherwise, while you may end up stabilizing this, if you treat the whole cornea, you'll have horrendous central flattening, which is often very irregular, and that will just defeat the whole purpose of doing this. And these people will actually lose vision after you do the cross-linking. So I think it's extremely important to shield the central cornea when you treat the abnormal periphery. Now, as far as the tectonic integrity restoration is concerned, this is what I meant about eye doing the subtraction process. I excise a wedge of the affected tissue. This can be either lamellar or full thickness. With the lamellar approach, basically, you can be more safe because you're not really breaking through the posterior layer. But with the full thickness approach, you get more effect because you're really cutting out that wedge and suturing it back. But if you don't do it very precisely, and it's very hard to do it precisely, it's all freehand dissection anyway. If you leave a little bit of the thin part behind, then the sutures can actually leak for quite some time, and that's not easy to tackle. So you'll have to take a call as to whether you want to do a lamellar or a full thickness approach. I'm no expert. I've probably done about 10 of these in the course of the last 25 years. So what I'm trying to state or commit is basically on my anecdotal experience. So this is how it looks when you do a wedge excision in the bottom. Basically, you put the sutures back. So you remove between 4 and 8, that thin crescent of abnormal tissue, and then suture the normal thickness peripheral cornea to that last 1 millimeter of cornea that you have in the periphery. And this is an example of one of the patients. Basically, we did him in November. Prior to the surgery, he had the against the rule bow tie. You can see the PMD related almost 12 diopters of cylinder. Post-surgery, this is ideally what you would like, about 6 diopters of with the rule. You want to convert them back about 50% to the other direction because that wound will stretch and relax. And as you start removing sutures, and it's peripheral, so you can start removing them even at 3 to 4 months. Half the sutures gone, 3.2 diopters, and all the sutures gone, about 1.5. I won't really pretend that all my 10 cases I did are like this. This is the best example. Some of them will not do as well. But if you can get rid of that inferior thin area and stabilize the surface, then you can put in a contact lens to take care of the residual astigmatism. But in the ideal case scenario, this is how you would like it to be. If it is combined with keratoconus, or if it's only a moderate degree of PMD, a large diameter DALC will work. Again, I've done a few of these, so this is just anecdotal. I can't pretend I have large case series. So this is the combined patient with the keratoconus as well as the PMD. So you make a large diameter DALC going all the way out to encompass the inferior thin area. And this person luckily did well. So it can work. The principles of DALC are pretty much the same. So PMD is not uncommon. I think in my experience, it's good to treat it early. There's no point in waiting and procrastinating. If it is early to moderate, I prefer a cross-linking to stabilize, and then I use a contact lens if required to improve the vision. But if it is advanced with tectonic destabilization of the cornea, then surgery is required, and I prefer the wedge. JK prefers the augmentation. And on top of that, you can add a contact lens if you don't get the desired refractive correction after your surgery. You have a little bit more astigmatism than you like, then you can fit it with a standard contact lens because you've gotten rid of the bulge now. So the lens will sit on the central cornea as well. So that's pretty much my experience with PMD. Thank you very much.
Madam.
Wonderful talk, SKR.
Thank you.
Because you are seeing a lot of cases, PMD is an unusual condition, but it's not very unusual in a busy practice, Arvind, you have so many patients coming. So sometimes even keratoconus, what we saw is we miss and do a small dal, and after that they develop after 5 years, 6 years, they develop a PMD. It will become very obvious because we will be looking at keratoconus and do a small, say 8 dal. So, madam, your experience, madam.
Before that, what Dr. Rao showed, I don't know whether Reddy remembers, Dr. MS used to do the same.
Yes,
He used to call it as wedge resection and suturing. And I don't know, as Dr. Rao's picture, even MSR's post-op cases, if you see, they look so well and the astigmatism really will come down. I have seen some cases after suture removal and all. And later I have tried it. Maybe somewhere I went wrong. I couldn't get that kind of excellent result. Maybe my selection also was not good. And then I kind of a hybrid method. I started doing what Reddy is doing as stromal enhancement. I used to do a lamellar resection of, you need not even do a lamellar resection. You remove the epithelium, sometimes it will be so thin. Then you put a kind of a wedge of tissue, the stromal tissue, and as a support, and then suture it. When suturing, make it very tight and almost anchor it to the limbus, that kind of surgery I have done in the, if you have a localized PMD like this. But as Dr. Rao mentioned, if you get a keratoconus with almost all around 360 degrees, sometimes thinning, then you have to go for a really large graft. And I have done few cases of tuck-in, what Ames group used to describe. The centrally, it will be just like a regular DALK, and the periphery, I used to do a tuck-in and again suture. But in all these cases, the results, as Dr. Rao mentioned, kind of little bit unpredictable. But if you can stabilize that condition and address that thinned area, I think that's what maximum will be, we can aim for these cases. And in the all around thinning, Dr. Rao, what is your this thing experience?
Sometime like a keratoglobus, madam, we just do like a king's cornea, a total replacement and suture it to the sclera all around. Just remove alcohol-assisted epithelium, and then put a large complete graft to the peripheral sclera, and then sew it. And that's typically for keratoglobus that we will do that as well.
SKR, I have two questions for you. One, what is the difference in the pathogenesis between PMD and keratoconus? Number one. Number two is, what is the little older patient PMD? Can we try toric IOLs for this patient, cataract? If so, what will be?
The first question, I don't think we know the answer. What is it in this? The process is somewhat similar in both, in that there's a irregular corneal thinning, which is progressive. But why it affects the center in one, the periphery in the other, I don't know. But I'm sure that is the reason why these two behave so differently. As far as the toric IOL is concerned, if you have stabilized the cornea and if you made sure that the condition will not worsen in terms of the corneal shape factor after your procedure, then I guess you could consider, because it's fairly regular against the rule astigmatism. Although the degrees of these astigmatism, particularly in the moderate cases, is way beyond what normal toric lenses can address. So if you're lucky enough to catch them in the early to moderate stage, then you could consider, but then these people will not have a cataract. So by the time they develop a cataract, they're 65 or so. And if you've not addressed the PMD before that, they will have huge astigmatism, which the toric lens just cannot encompass. We're talking about 12, 13, double-digit astigmatism.
We had a patient, there's a reason why I asked whether you had a patient with a PMD, little older patient, 50 plus with cataract also. You're about -8, -9. So astigmatism, and we put a customized toric lens, which is made by the IOCAR. And even after the surgery, after the access, everything is fine. And according to the saying, we also did an eye trace post-operatively. Despite all that, the patient is still having a residual astigmatism of about 4 or 5. Yeah. So that's the reason why I asked the question to you and all the expert panelists here.
The toric lens is designed to take care of some amount of regular corneal astigmatism. This is an irregular and an excessive corneal astigmatism. So without tackling the cornea first, I think it is difficult to use the toric as your sole mode of management. Yeah.
So as it is an irregular corneal astigmatism here, the instruments will measure and average it off to some value, which is may not be the correct value. But the 3 to 4 diopters is fairly good landing up after PMD. They can wear it. Whereas 8 to 10 diopters astigmatism, they cannot wear glasses.
The surprising thing is the other eye is plano now for her. And this eye has got about 4-5 cylinder. So yeah, she's...
So manufacturing also, we don't know, but the measurement itself is becoming very difficult. Astigmatism, little bit irregularity, they average it off. Keratometry astigmatism, which is the topographers.
Yeah, Bhaskar.
So the one thing that I just wanted to add would be when you're doing a CXL for PMD, it's important to actually measure the thickness at the thinnest point manually. Sometimes the Pentacam machine or whichever machine you're actually doing your preoperative assessment might not take the thickness till the periphery if you have kept a zone of 8 mm as such. And it might actually show you a value of around 300. Whereas if you go at the shine plug image and or the OCT and you actually measure, that area will be thinner. So if you're going to be doing a cross linkage, you still need to maintain the thickness in that area to be reasonably acceptable for us to do a cross linkage. Other thing I would ask Dr. SKR would be whether he decenters the beam inferiorly towards the area of the thinnest point as such, and how do you protect the limbus? Do you keep a shield in the limbal area, or you put a blob of viscoelastic on the limbal area to protect the limbus?
I think the thickness is not so critical in this particular situation. We're so fussy about the thickness in a keratoconus because you're talking about the central endothelium there. And in a thin cornea, if your beam gets past the stroma and hits the endothelium, then you're going to have a bit of scarring and edema, and you don't want that centrally. This is peripheral, so honestly, I don't care. Even if it happens, the scarring is actually going to help this whole process. So I don't really care about the thickness there. If I think I can stabilize it, I will. As far as the limbal protection is concerned, it's purely visual because I've already got a large blob of a sponge sitting on the center. It's very unlikely I can get another ring in the periphery and then try and treat the center. But eye does keep making small movements. And I don't think it's that important there. I don't think the limbus gets hurt that much anyway. So we have a 9 millimeter beam. So we just decenter it slightly, and the assistant who's doing the process after I remove the epithelium sits there and pays extra care that they keep adjusting it to keep it on the thing. So occasionally, I guess it will go past the limbus. But so far, we've never had anybody show any limbal insufficiency because of that.
Fine. Thank you very much, SKR.
Thank you very much, SKR, sir, for your insights and talk on PMD. So we invite the next speaker, Dr. Vandana Sundaram from Shankara Eye Hospital.
Welcome, Vandana.
Thank you, sir. At the outset, I would like to thank Tnoa and my mentors at Shankara for giving me this opportunity. Rose Bengal photodynamic therapy for non-resolving infectious keratitis. So in the current scenario, there is an increase in antibiotic resistance as well as a shortage for donor cornea. So there is always a need to develop alternate treatment modalities in patients with non-resolving infectious keratitis. So what are the options? So there are two. One, it could be either a PAC-CXL or a Rose Bengal PDT. PAC-CXL, further studies have shown that it has not been very effective, especially in the cases of fungal corneal ulcers. Here in Rose Bengal PDT, Rose Bengal is a photosensitizer that gets excited by green light, and it undergoes a reaction with ambient oxygen to form a singlet oxygen and reactive oxygen species. So this interacts with the intracellular components and produces cell inactivation. So the Baskin Palmer group started their research on Rose Bengal photodynamic antimicrobial therapy around 2016 and 2017. So they started with in vitro studies where they found a good response to Pseudomonas as well as Fusarium isolates, and then later moved on to human trials, and they found it to be very useful in patients with non-resolving infectious keratitis. So how about the safety? It has been proved on rabbit models that there is no damage to the endothelium or the limbal stem cells. And Rose Bengal, it interacts strongly with the collagens. Therefore, its penetration is limited to only about 100 to 150 microns in healthy stroma. Whereas in patients with with corneal ulcers and inflammation, the dye diffusion is enhanced. So next, coming to Rose Bengal and its percentage. So be it either 0.1%, 0.15%, or 0.2%, studies have shown that there is no big difference in the outcome. So in our hospital, we tried Rose Bengal photodynamic therapy for a few patients with non-resolving keratitis. So the procedure was done in the OR under aseptic precautions and under topical anesthesia. So after epithelium scraping of about 8 millimeters, so Rose Bengal 0.2% was used. 1 drop every.
Slides are not moving.
I'm talking, sir. Only the next slide.
Yeah, it's okay.
Okay.
So for a period of around 30 minutes. So after this, 535 green light was applied. So here we used 2 settings. The first one being a 5.4 joules per centimeter square for a period of 3 minutes and a power of 30 millivolts. And a second setting of 2.7 joules per centimeter square for a period of 1 minute and a power of 30 millivolts. So totally around 8.1 joules for a period of 4 minutes. Here we did not use any limbal shield or anything of that sort, because in our machine, and as you can see here, we could change the size of the aperture. So here we move on to a few clinical cases that we tried Rose Bengal PDT on. So this patient was a 50-year-old gentleman who was referred to us. Initially, he had a corneal ulcer, which was only around 2 to 3 millimeters. And in spite of good compliance and starting on Natamet hourly, there was an increase in size of the lesion. So he came to us, we repeated the scraping, and it was found to be fusarium keratitis. So we continued Natamet, did not change any of the eye drops, and did a single session of RBPDT. And as you can see here on the picture on the right, 10 days post RBPDT, there was a good resolution of all the infiltrates, and scarring had set in. Another patient, this was a very anxious patient, 24 years old, referred to us from Kerala. Initially had an ulcer, which was only around 2 by 3 millimeters. And then it was increasing in size, again, not responding to therapy. So this was one of the patients that we tried RBPDT on, and just 4 days post RBPDT, almost 80% of the lesion had completely disappeared. And again, it's important to note that we did not change any of the topical antibiotics. We just augmented the treatment with Rose Bengal PDT. So this patient was another patient with who was 90 years old with recurrent viral stromal keratitis. And he was finding it very difficult because every 3 months once he kept having a recurrence, and he was finding it very difficult. So we tried, we continued the topical as well as systemic antivirals for him, and then did 1 single session of post RBPDT, where we used only a single session of 5.4 joules, not the 8.1 joules. And 10 days post RBPDT, he fared really well with complete, as you can see here, the picture on the right. So basking on all this success, we tried to do this in a few more patients as well. So this patient again was treated for a period of 2 weeks, culture proven to be fusarium keratitis. And we did, and he was on Natamet, voriconazole, as well as itraconazole and cycloplegics. So we did a session of RBPDT and waited to continue the same eye drops and waited at least for a period of 2 weeks post PDT. But still, he did not show any response. So there was an increase in hyperpion, and there started to be a superior extension of the lesion as well. So this patient, ultimately, he had to undergo a therapeutic penetrating therapy. This is another patient, 55-year-old female, been treated for fungal keratitis for almost a period of 1 month. So intrastromal voriconazole was given, intrastromal amphotericin was given, and she even had a intracameral voriconazole given elsewhere, and for almost a period of 1 month. So then she was referred to our center for further management, and she was already on a cocktail of medications, and the culture did not show any growth because she was on multiple medications for a period of 1 month. So we did a RBPDT, continued the medications, and then waited for at least 2 weeks post RBPDT. And as you can see here, there was an increase in epithelial defect, should not show much of response. There was an increase in hyperpion, and there was a temporal extension of the lesion as well. So ultimately, this patient, we had to do a therapeutic keratoplasty. So she underwent a therapeutic DALC, and she fared really well. There was no recurrence of the lesion. The picture on the right, you can see the 1 month post-op as well. And it's been 6 months post-treatment, and she's faring really well. So what are the parameters that we really need to explore? So this is a proven treatment that has been done for non-resolving infectious keratitis, but still there are certain things that we have to explore more. One being the total irradiation energy. The Baskin Pharma group, they did the 5.4 joules for 15 minutes in most of their patients, and they found good results. And again, the time duration in our study, what we did was we did 5.4 joules over a period of 3 minutes. And the third thing that has to be explored was, will RBPDT, will patients benefit from RBPDT early in the course of the disease? Could it be a regular adjuvant in the treatment of microbial keratitis? And the fourth one is the repeat treatment. So the indications for repeat treatment and the irradiation time and duration, irradiation energy and duration for repeat treatment have still not been established. So these are the parameters that we have to explore more when it comes to Rose Bengal PDT. Thank you.
Madam.
Yeah. Yes, doctor. Actually, this is an interesting field now everybody is exploring. And as you said, the Rose Bengal, they moved over because it's compared to riboflavin, this has better coverage against fungus as well as even acanthamoeba. The Boston Farmer group now, they are more working on acanthamoeba keratitis with this one. So acanthamoeba also, even in the in vitro, they proved that it is effective. And the mechanism, they say always for all the PDTs, they used to say one is antimicrobial effect, the other one is increasing the collagen resilience, for further degradation. And even for riboflavin, the CXL, PAC CXL, this used to be my argument whenever, like even Dr. Prajna published that it is not effective in fungal, all these cases. So always when you want to try it in the later stage, when it has become a total necrotic material, I don't think where it is not only infection, the body immune mechanism also is acting. So it's a pus sitting there. And I don't think any of these kind of things are going to be effective there. So as you pointed out correctly, I feel my gut feeling that whatever you want to try, you try in the early period. Then maybe there, as your initial 2 cases, you may get good, as an adjuvant therapy, you may get good results. That's my take in this treatment method. Again and again, they did even Regar. I think they tried in the later cases. And at least in the early cases, they have shown that it is not harming much. That much they were able to find out. And this study, a proper randomized study is on the way in Aravind along with the Proctor Foundation. But I don't know. I don't think still it has started because of the COVID, it got delayed. Maybe with further research, we may get a good solution for this kind. But the 3 questions what you have raised is really, and Boston Farmer report have shown that at least half of their patients, they have done at least twice.
Yeah, yes,
so if they feel that it is responding, they have gone for another thing also. And in one patient, even 3 times they have done. That's what they have shown. And 72% of the cases they could heal. Only the rest of it has gone for TKP or whatever. So I think this is a good mode of therapy which we need to explore a little bit more. And maybe we should not shy away from this. And maybe we have to think about doing it in the early period as an adjuvant rather than waiting for a later period, even including the intrastromal. No point in waiting for topical to take effect, wait for 2 weeks and declare that it is not acting and then go for intrastromal. I think it should be done as an adjuvant in the earlier period.
One case we failed, madam. 2 cases we failed. We realized that he also looking so big. We sent for RBPDT. We put the stain and did it. When we saw the pictures, the epithelial defect is small than the ulcer. So under the epithelial defect, we are not. So then we realized we had to scrape. We are a bit worried, scraping the ulcer may spread the everywhere on the healthy cornea, thinking that we didn't scrape. So we did a mistake in first, at least 2 cases, we did that mistake. After that, we are scraping 8 millimeter, whatever may be the ulcer size, we are scraping it off and started doing. But very limited, we had some of the ulcers have come down in our place. So it's almost 1.5 years now. We have machine for 2 years now. 1.5 2 years. It took around 2 years to manufacture the machine to cut the correct wavelength and one.
Yeah, for the initial cases, actually, one of the fungal cases, the lesion was actually only inferior. So that was actually one of the first 2 or 3 cases. So I just scraped the epithelium around 4 mm around the ulcer and we just applied RBPDT. That area cleared, but somewhere I think around from the satellite lesion, somewhere small satellite lesion, he developed a new lesion superiorly for the, superiorly. So that's when the second and third cases, we made sure that we scraped entire 8 mm of epithelium irrespective of where the ulcer location is. And like you said, ma'am, the Baskin Pharma group have repeated their this thing. At 2 weeks, they've repeated RBPDT for patients. And at 2 weeks, for some patients, they've actually repeated only with half the energy. And with 1 or 2 patients, they've done it with only 0.9 joules of energy. So that's why the repeat treatment indications and irradiation energy probably have to be established more. Since we were just starting for those 2 patients, we didn't go for a repeat treatment. And those 3 or 4 patients with the single treatment, they fared really well. So we didn't have the need to go for the repeat treatment.
Since it works best in the superficial ones, do you have any pythium in your series? Because if it works against pythium, then that would be a boon. So that's the one that even if you catch it superficially, it doesn't do so well even with linezolid and all that. So some of the other superficial ones will respond anyway to Natamet. So it's a good adjunct, but not necessarily the best. And while you're also working on the parameters of the machine and the radiation, the duration and all that, maybe you can look at OCTs as well, because some of them did well, some of them didn't do well. So if you can define a cutoff depth above which this is likely to work well, or when the fungus creeps below that level, then this is not a good option. Then you don't waste time. You can take them up straight away for therapeutic and not really.
We actually did that, sir. We actually did ASOCT for all the patients prior to RBPDT, and especially the non-resolving cases that we had, all of them had infiltrates beyond 300 microns. So what we saw is that beyond 300 microns, they did not fare well with RBPDT. And
that would be a very useful guideline, because if you can define that limit, then you don't waste time, because once you get a new procedure, when everybody starts doing it, they will apply it to everything. And then you're just delaying the inevitable, whereas you could have done the therapeutic earlier. So I think that would be one very important aspect for you all to concentrate on and come up with a solid number and say, if it's above that, this has a very good chance of working. Below that, the chances are going to be minimal.
In our limited series, that number was 300 microns on ASOCT. And I think beyond 300,
that kind of makes sense. Yeah, that makes sense. Because just like with the actual riboflavin-induced cross-linking process, we know it stops at a point, and you really want it to stop at a point, because it goes beyond that, you're going to kill the endothelium anyway. So that kind of makes sense that wherever the cross-linking is maximal, that is where this will work. So if it is 300, that's a good number if you can refine it. And, yeah.
Fantastic.
Nice.
Very good. Thank you very much, Dr. Vandana, for sharing your experience on the Rose Bengal PDT and all the panel for healthy discussion. So now we invite our last speaker for the day, Dr. Samruddhi from Shankara Eye Hospital.
Good afternoon. I would like to thank TNOA and my mentors for allowing me to present on this topic. So I'll be discussing about the diamond burr and its versatility application in various corneal conditions. So a burr is basically a small rotatory cutting tool. And besides the industrial applications, burrs were first found suitable in dentistry almost 300 years back, where they used 3 types of burrs like stainless steel, tungsten carbide, and diamond, for various indications like removing decayed cavities and fillings and cleaning the surface plaques, because the tool is able to grind the hard enamel of the tooth without damaging the soft tissues in the oral cavity, even if they are touched. So that is how it found its application in dental work originally. And subsequently in ophthalmology, we have been using diamond burrs out of these 3 types. Which most commonly for the well-known indication of recurrent corneal erosions. So there are multiple types of burr heads that are used. The first is the 0.5 and 1 millimeter burr head, which is typically used to remove embedded corneal foreign bodies or rust rings. Then is the 2.5 and 3.5 millimeter diamond ball, which can have fine or medium grit particles. So the fine grit is usually used for polishing in recurrent corneal erosions, whereas the medium grit is more commonly used for more adherent and thicker lesions like band-shaped keratopathy. And the next are the diamond wheels, again of fine or medium grit. And these are most commonly indicated for cases of corneal haze post PRK. So these are the various indications for which we found the diamond bar to be useful. The most common indication for using a diamond bar is in the treatment of recurrent corneal erosions. The loose epithelium is first peeled off along with the rim of surrounding epithelium. The bar is then used to polish the surface. The central area is polished first, underlying the erosion, followed by polishing of the periphery. Antibiotic drops are instilled and a bandage contact lens is put. The next indication is a shield ulcer. The bar can be safely used in lesions involving the visual axis as it does not cause any residual stromal scarring. The diamond bar can also be used to aid the process of EDTA chelation for band-shaped keratopathy. As seen from the surgical recording timings, the entire process of EDTA chelation for band-shaped keratopathy can be completed in just 4 to 5 minutes with the help of a diamond bar, in contrast to the usual process, which takes around 15 to 20 minutes. The ocular surface is polished by the diamond bar, while EDTA is simultaneously instilled drop by drop. The next indication is a corneal scar causing an irregular corneal surface following a pterygium excision surgery. This patient presented to us 3 years following pterygium excision surgery for a double pterygium. He presented with a nasal and temporal corneal scar with an irregular corneal surface. We can see that the scar tissue was removed, and this was followed by polishing of the surface with a diamond bar both nasally as well as temporally. Next is a case of epithelial hypertrophy with underlying scarring post deep anterior lamellar keratoplasty. The bar is used to gently scrape the hypertrophic epithelium and to polish the underlying surface. We can notice a real-time clearing of the hypertrophy intraoperatively. It is also important to note that the scar has been cleared while at the same time maintaining the graft-host junction integrity. So as we can see, the diamond bar can be used for a multitude of corneal conditions, and there are multiple advantages of using this instrument. One is that it requires minimal surgical skills. It is very easy to use. It does not cause any corneal scarring, and so we can safely use it even for lesions that are involving the visual axis. It has a very low rate of recurrence when we use it for the treatment of recurrent corneal erosions. And retreatments are very easy. There is no chance of perforating the cornea, and it also does not cause any significant refractive shift. Thank you.
Wonderful, wonderful presentation.
Thank you, sir.
Very nice. Can you use this burr instead of this PTK?
For what, sir? For
PTK instead of PTK.
For RC, recurrent corneal erosion.
Recurrent corneal erosions or any?
Yes, sir. Slowly we stopped PTK for recurrent corneal erosion, sir. One or two patients who are 6/6 sharp vision, they started complaining of after PTK. They start complaining of little diminution of vision, though they have 6/6 parts. After PTK changes little bit refractive error, they start. So we are now routinely doing all cases diamond burr only for RCE, and it's not changing the refractive, but only we have to do for a little bit long time.
What is the cost, JK?
It's very economical, sir. One burr costs around 10,000 something with the 2 or 3 attachments.
Okay.
And especially post PRK haze, it's very good. Unfortunately, we didn't, recording was missing somewhere. It comes out very nicely post PRK haze if you want to remove. And it comes back, vision also comes back very nicely to the back to the normal.
I think most of the indications for PTK can be managed with this diamond burr easily and more elegant also to the results to look at. I think it's a good replacement.
Anybody else is using? SKR, Bhaskar, Revati?
Somehow in ophthalmology, very few people are using. We want to popularize, so we are struggling to. Coimbatore, a lot of people started using, but
I'm using,
sir.
JK,
Yes,
I'm using regularly for pterygium surgeries. Pterygium surgeries, I'm regularly using. For many years I've been using. How do you sterilize, JK? How do you sterilize?
So the tips can be autoclaved, sir. The hand, the body part, we have to just disinfect with alcohol, or you can keep it in a gas sterilizer, Evo gas. But alcohol wiping is good enough because it's a completely stainless steel instrument. There is no chances of contamination that much unless you really keep it in a dirty place.
Because there are cells, you'll have to put the batteries inside.
The cell will last for a long time, sir. It comes for 4 to 5 months, one cell, alkaline Duracell.
Sterilizing this, that is what with the.
You don't need, the cell is inside, the cover outside.
Just keep it outside.
Just wipe with alcohol, and the tips can be, which comes in contact with the patient, tip can be autoclaved.
Any particular brand you recommend anywhere you can get it?
The Algar brush only they come in available in India. That's made in USA. And next I am starting to make it. Maybe next year I will.
Once you know where you can get it, many people might buy it and then start using it. It's not available.
Somehow it is there in the books. It is there for 40-50 years. Initially, the Russians are using a lot, but that's very expensive. It used to be $800, $1,000 when I'm doing my PG. PG means I'm telling in 92, 93. Because of that cost, now it became very economical, $100, $150 international market, and it's available in Amazon. That is easy. Amazon.com. It is available.
It's around 7 to the 10,000 only. Costing around 10,000.
The disc is costly, sir. If you buy the disc for PRK and some conditions like lattice dystrophy, if you want to scrape in the center or a Reese buckler, that's up. Then you have to buy the disc. The disc is around 5,000, but it lasts for a lifetime.
Have you tried it in MCD, Reddy? The superficial large lesions sometimes
No,
lead to
madam.
decay.
Now, one by one, we are adding. Now we came to RCE. Surprisingly, nobody is trying in for RCE in the world. We didn't see any video, any one apart from mentioning in the literature. It works very well for RCE.
Wonderful, fantastic.
Just conclusion, sir. Sir, audio cut. Somebody cut your audio.
We are exactly on time, I said.
Yes.
The first time ever, a TNOA Connect series is concluding on time. Normally it goes up till 1:30, 2 o'clock. And normally I find that people don't watch webinars for more than 1.5 hours, 2 hours. If it goes beyond that time, that the critical period is gone. So I think you've done a wonderful job. Manoj, you can give the vote of thanks.
So I take this opportunity to thank the TNOA and TNOA beloved President Dr. Mohan Rajan sir, TNOA ARC Secretary and other office bearers, and today's speakers, Dr. J.K. Reddy sir, Dr. Siddharthan sir, Dr. Bhaskar Srinivasan sir, and Dr. S.K. Rao sir, Dr. Vandana ma'am, and Dr. Shamruddhi, and all the moderators.
Dr. Revati.
Dr. Revati ma'am, she is a moderator, sir. She's a panelist.
Okay, yeah.
So I thank the moderators for today's Cornea Connect series. Dr. Revati ma'am, Dr. Bhaskar Srinivasan sir, and Dr. S.K. Rao sir. And my TNOA coordinator colleague, Dr. Nishant, unfortunately, is also held up with another meeting. So was coming and going. And, thank Numerotech, the tech guys behind the scene, the IT department of TNOA, Mr. Sai and Mrs. Manjula, and the sponsors for the event, Zivira, and all the participants and the audience for today's attending the webinar. This is the 10th TNOA Cornea Connect webinar series from Dr. Mohan Rajan sir. So it's a very privileged and great honor to be here today. And thank you all for making this event a grand success. Thank you very much, everybody.
Thank you very much. Once again, I would like to thank J.K. Reddy and the Shankara Eye Hospital for the wonderful opportunity of being here and making a fantastic, really, all the topics are so good. All the speakers were really fantastic. And then lots of learning were there, and very innovative methods were also learned and were also shared. And stay tuned for more TNOA activities. Next week, we are going a little slow because of the AOS conference. But Jan 17th, we are having the masterclass on UVA, but none other than Dr. Jyotirma Biswas. We also have Singapore, Dr. Chisoon Fake as one of the faculty for that. And Jan 18th is the Walk the Talk series with Dr. Prem Raj. And Jan 19th, we're going to have a TNOA, another Connect series with on infectious keratitis with the Shankar Nitralaya. So again, let's meet again in Mumbai. Those who are coming for the